What the primary care provider should know about obstructive sleep apnea syndrome. This hour-long educational session was developed for primary care providers practicing in the Los Angeles County healthcare system by the Sleep Medicine Specialty Primary Care Work Group. The project was funded by the American Sleep Medicine Foundation Project Award. At the end of this session, you should understand the basic pathophysiology that leads to obstructive sleep apnea. Be informed of the complications and consequences of obstructive sleep apnea syndrome. Know how to screen for patients at risk for obstructive sleep apnea syndrome. Be aware of the algorithm used to evaluate patients with obstructive sleep apnea syndrome, and be familiar with the current treatment and disease management of patients with obstructive sleep apnea syndrome. 1 CME unit can be earned on completion of the session. The following 5 slides are the pretest questions for those who intend to claim CME credit. Number 1. In addition to obesity and male gender, which of the following is a strong risk factor for obstructive sleep apnea syndrome? Choose one. A. Inactive lifestyle. B. History of stroke. C. Cervical spine disease. Or D. Use of sleep aids. Number 2. Which of the following physical findings does not indicate high risk for obstructive sleep apnea syndrome? A. Mallampati score 3. B. Neck circumference 19 inches. C. Mallampati score 1. Or D. Tonsillar score 4. Number 3. The Stop Bang questionnaire, A, can be used in lieu of testing to identify patients that will benefit from CPAP treatment. B, is a simple screening test to identify patients at risk for obstructive sleep apnea syndrome. C, predicts CPAP adherence. Or D, should only be administered by experienced personnel. 4. Which of the following measures daytime sleepiness? A. Polysomnography. B. Home sleep testing. C. Epworth sleepiness score. Or D. Stop Bang. And 5. To gain optimal benefit from using CPAP, a patient should choose one. A. Use it 4 hours per night, 5 nights per week. B. Use it whenever sleeping. C. Sleep in the supine position whenever the mask is in place. Or D. Use it with a chin strap. Let's start with 2 cases of obstructive sleep apnea syndrome. The first is a typical case, a middle-aged man with hypertension and type 2 diabetes mellitus. His wife complains that he snores, snorts, and gasps while sleeping, and that he falls asleep unintentionally in front of the TV. On exam, he's obese with a thick neck. His BMI is greater than 30, and his blood pressure is elevated. His neck circumference greater than 17 inches and Mallampati score of 4 put him at risk for obstructive sleep apnea syndrome. The second case is less typical but not uncommon. A 20-year-old student having academic difficulties and daytime sleepiness despite seemingly adequate time in bed. His roommates complain that he snores loudly. He recently fell asleep at the wheel and crashed his car. He has had nasal stuffiness and recurrent pharyngitis. On exam, he's a thin Asian man with a normal BMI, but distinctive craniofacial features, facial flattening, and retrognathia. He also has 3+ tonsillar enlargement. Both of these patients could have a sleep study that looks like this. This is the summary page for a split-night polysomnogram. During the first part of the night, the patient was monitored without treatment. When obstructive sleep apnea, or OSAS, was evident, titration to determine a therapeutic CPAP level was done. The different channels show sleep stages, arousals from sleep, snoring, apnea and hypopnea events, and oxygen saturation. During the monitoring period, you can see that sleep is fragmented with repeated arousals, and there are tremendous fluctuations in oxygen saturation that accompany recurrent respiratory events. During CPAP titration, the patient maintains sleep with few arousals. When a therapeutic CPAP level is attained, apneas and hypopneas disappear and oxygen saturation remains normal. Let's zoom for a 3.5-minute segment of the monitoring period. The airflow channels show repeated apneas and hypopneas, each followed by a snore, an arousal, steep oxygen desaturation to the low 70s, high 60s, and then a hyperventilatory recovery. Sleep apneas and hypopneas are defined by airflow cessation or reduction and drop in hemoglobin oxygen saturation. RERAs, or respiratory event-related arousals, are arousals preceded by airflow reduction but without oxygen desaturation. The Respiratory Disturbance Index, or RDI, is the average number of apneas, hypopneas, and RERAs per hour during the study. A RDI greater than 5 is considered abnormal. Obstructive sleep apnea syndrome, or OSAS, severity ranges from mild, with RDI 5 to 14, to severe, with RDI greater than 30. Let's talk about the pathophysiology behind OSAS. The fundamental anatomical problem is an imbalance of soft tissue and airway space within a rigid upper airway bony enclosure defined by the maxillomandible and vertebral column. When there is a normal amount of soft tissue within a normal-sized bony enclosure, the airway remains open during wake and sleep. In situations where there is extra soft tissue, like obesity or adenotonsillar enlargement, there is increased pressure on the airway. It narrows and is vulnerable to collapse. There are also situations where the craniofacial structure results in a smaller bony enclosure. Now, even with a normal amount of soft tissue, there is increased pressure on the upper airway, making it susceptible to collapse. The P crit is the pressure inside the airway needed to keep it open. Patients with OSAS have a higher P crit. The pathophysiologic basis for OSAS is more complicated than just the anatomic component. There are also non-anatomic components that either promote airway patency or collapse. An important phenomenon keeping the airway open involves contraction of the pharyngeal dilator muscles. This occurs during a reflex mechanism that is initiated during inspiration. During sleep, this reflex is diminished and the pharyngeal dilators are less active. Another force for airway patency is traction on the upper airway from the expanded lung. An important force causing upper airway collapse is the negative pressure generated during inspiration, especially if there is insufficient pharyngeal dilator activity to resist this negative pressure. We've already discussed how changes in the upper airway anatomy can result in a higher P crit needed within the airway to keep it open. In addition to excess soft tissue and craniofacial structure, the supine position promotes a higher P crit. There are two other components that may promote sleep apnea. Ventilatory instability, referred to as high loop gain, can lead to periodic breathing that accentuates cycling of apneas or hypopneas with hyperventilatory recoveries. A second component is a low arousal threshold that precludes adjustment to reduced airflow during sleep. A low arousal threshold results in sleep fragmentation and daytime sleepiness with less fluctuation in oxygenation. So in recent years, we have gained appreciation for the complexity of OSAS that can result in distinct clinical pictures in different patients. Looking at populations of individuals with OSAS, 4 phenotypic causes have been proposed. You can remember them by using the PALM acronym. P is for high or less negative P-crit, representing the anatomic component of OSAS. This is present in most patients with OSAS. A is for low arousal threshold that results in sleep fragmentation and daytime sleepiness with less fluctuation in oxygenation. L is for high loop gain that causes unstable ventilation, and M is for muscle responsiveness or impairment of the pharyngeal dilator reflex, leading to flabby pharyngeal dilator muscles that render the upper airway vulnerable to collapse. The combination of these phenotypes determine how a patient with OSAS presents clinically. OSAS is a common condition. It's estimated that more than 18 million American adults have OSAS, diagnosed or undiagnosed. This compares to 18.7 million with asthma and an estimated 25.8 million with diabetes. Most OSAS cases, an estimated 75 to 80% of severe cases, remain undiagnosed. This presents an important challenge to PCPs. OSAS prevalence is higher in older adults and in racial ethnic minorities, possibly related to craniopharyngeal features. Recently published findings from the Hispanic Community Health Study found a 25% prevalence of OSAS among Hispanics of various origins throughout the United States. The prevalence of moderate to severe OSAS was almost 10%, and only 1.3% had been diagnosed previously. Why should we care about OSAS? First, because it causes disabling daytime symptoms and functional impairment that decrease quality of life. Many OSAS patients find themselves unemployed, some having been fired for falling asleep on the job. Daytime impairment may also lead to marital and family problems. Untreated OSAS individuals are at high motor vehicle and occupational accident risk. Several studies have confirmed a MVA risk of up to 5 times greater in untreated OSAS drivers. The type and extent of medical complications of OSAS have become clearer over the last few years. OSAS is associated with and may contribute to the metabolic syndrome, a cluster of conditions that include hypertension, hyperglycemia, increased visceral fat, and hyperlipidemia. Metabolic syndrome increases risk of heart disease, stroke, and diabetes. Numerous studies have now confirmed that OSAS contributes to hypertension that improves with CPAP treatment. There is a clear association between moderate to severe OSAS and risk of stroke, coronary artery disease, and cardiac arrhythmias, especially atrial fibrillation. Studies have even suggested that OSAS may predispose to cancer and non-alcoholic fatty liver disease. You will see in a minute that untreated OSAS patients have high cardiovascular mortality risk and may develop obesity hypoventilation syndrome. Put these complications and consequences together, and it's not surprising that a variety of studies have documented that OSAS leads to high healthcare utilization and cost. Here's an example of the evidence that OSAS is a treatable cause of cardiovascular disease and mortality. This Spanish study followed a large number of patients in a sleep clinic network over 12 years. The red line shows that the cumulative incidence of non-fatal and fatal cardiovascular events, including stroke and myocardial infarction, was significantly higher in severe OSAS patients compared to not only controls and primary snorers without OSAS, but also to patients with mild or treated severe OSAS. The odds ratio of cardiovascular death in the severe untreated OSAS group compared to controls was almost 3, whereas it was the same for those who were treated. A particularly severe complication of OSAS, especially with extreme obesity, is obesity hypoventilation syndrome, daytime hypoventilation associated with obesity. It's also been called Pickwickian syndrome after the fat boy in Charles Dickens's Pickwick Papers. About 10 to 20% of OSAS patients have obesity hypoventilation syndrome, and more than 90% of patients with obesity hypoventilation syndrome have OSAS. The diagnostic criteria of obesity hypoventilation syndrome are BMI greater than 30, daytime PCO2 greater than 45, and no other cause of hypoventilation like COPD, hypothyroidism, or kyphoscoliosis. The obesity hypoventilation syndrome is associated with substantial morbidity and mortality. Patients with obesity hypoventilation syndrome have recurrent cardiorespiratory decompensation that usually requires hospitalization, often with admission to the ICU. They have high in-hospital as well as high overall mortality rates. Several studies have shown that individuals in all age groups with untreated OSAS have high healthcare utilization and costs, about twice higher than matched controls. The higher utilization and costs has been due to greater hospitalization days, outpatient visits, and drug costs. It's reversed with CPAP use. The concept of integrating sleep medicine services into organized healthcare systems is relatively new. OSAS is a highly prevalent treatable disorder that affects the well-being of patients and their families, has significant medical complications, social and public health consequences, and leads to high medical utilization and costs. As such, recognition and treatment of OSAS fits well with the goals and operational model of accountable care. The diagnosis and management of OSAS is best accomplished through a partnership between primary care provider and sleep medicine center. Within the LA County Health System, it's essential that the approach to OSAS is patient-centered and considers language-appropriate communication as well as diversity in cultures, groups, and communities. The partnership between PCP and Sleep Medicine Center follows 5 steps. The first step is identification of patients at risk for OSAS by the PCP. The second step is the initial clinical assessment by both the PCP and Sleep Medicine Center. The third step is testing completed by the center. The fourth step is treatment and education. With the sleep test results, the center provides a treatment plan and education. Patients treated with CPAP receive adherence and efficacy monitoring. Finally, in Step 5, patients are followed up in clinics, continuing the same partnership between PCP and sleep medicine specialist. The process begins when the primary care team identifies a patient at risk for OSAS and refers him or her to the center for evaluation. In some cases, patients are referred to the center from specialty clinics or during hospitalization. Here are the most important OSAS risk factors that should alert the PCP to the possibility of OSAS. It's important to remember that these risk factors may not be present in some patients with significant OSAS. Overweight, i.e. BMI greater than 25, but especially greater than 30, male gender, and large neck size greater than 17 inches for men and greater than 16 inches for women are the classic risk factors for OSAS. Enlarged tonsils, especially important in children, also put adults at higher OSAS risk. In both overweight patients and those not overweight, craniofacial features may create a small upper airway bony enclosure that predisposes to OSAS. This may occur with retrognathia, recessed maxilla and mandible, and high arched palate. A high arched palate may be present with a variety of congenital syndromes, like Turner's syndrome. Family history is a risk factor. Genetic factors may predispose to several of the phenotypic causes of OSAS. Patients who have had a stroke are at high OSAS risk. Endocrinopathies, especially hypothyroidism with myxedema and acromegaly, frequently are complicated by OSAS. Hypertension can be viewed as a risk factor as well as a complication of OSAS. And patients with neuromuscular disorders often have central, obstructive, or combined sleep apnea syndromes. Facial and pharyngeal muscle involvement puts these patients at risk for OSAS. Here are some of the common symptoms that should alert PCPs to the possibility of OSAS. Excessive daytime sleepiness, loud snoring, witness apneas, restless sleep and awakenings at night, nocturia, unrefreshing sleep, nocturnal or early AM chest pain, sexual dysfunction, AM headache, cognitive problems, depression, and job loss, especially falling asleep on the job. Physical findings that put patients at OSAS risk can be assessed by the Mallampati and tonsillar enlargement scores. The Mallampati score is performed by asking the patient in a sitting position to open the mouth and protrude the tongue. Scoring may be done with or without phonation. The score may vary depending on whether the tongue is maximally protruded and if the patient is asked to phonate. With Mallampati Class 1, the soft palate, uvula, tonsillar fauces, and pillars are visible. With Class 2, soft palate, uvula, and fauces are visible, but the tip of the uvula is masked by the base of the tongue. Class 3, only the soft palate and base of the uvula are visible, and with Class 4, only the hard palate is visible. Mallampati 3 and 4 scores indicate high OSAS risk. The tonsillar score can range from 0 to 4. Score 0 indicates prior tonsillectomy. With score 1, the tonsils are hidden within the pillars. Score 2, the tonsils extend to the pillars. For score 3, the tonsils extend beyond the pillars. And for scores 4, the tonsils extend to the midline. Patients with tonsillar scores 3 and 4 have higher OSAS risk. Once a patient is identified to be at risk for OSAS, the PCP and Sleep Medicine Center work together to complete an initial clinical assessment. The initial clinical assessment consists of an OSAS risk score acquired from the stop bang tool and completion of a comprehensive sleep intake questionnaire and daytime symptom assessment tools at the Sleep Center. The stop bang tool is a well-validated screening instrument for OSAS risk. It's used by the Sleep Center to decide whether a home sleep test or an in-laboratory polysomnography is appropriate as the first test. The stop bang tool has 8 yes/no responses to clinical symptoms or risk factors associated with OSAS. Patients who have 3 or more yes answers are scheduled for home sleep testing. If the home sleep test is positive, that patient can proceed to home CPAP titration and treatment without having to spend a night in the sleep lab. Patients with fewer than 3 positive stop bang questions and those for whom this home sleep test is non-diagnostic are scheduled directly for in-laboratory polysomnographic testing. The polysomnogram serves as the gold standard for OSAS diagnosis. The initial clinical assessment at the Sleep Medicine Center includes a comprehensive sleep intake questionnaire that screens for a wide variety of sleep disorders, defines sleep habits, and elicits nocturnal and daytime symptoms. Daytime symptom assessment tools provide a more objective appraisal of daytime sleepiness and functional impairment. The daytime assessment instruments used are the Epworth Sleepiness Scale and the Functional Outcomes of Sleep questionnaire. The Epworth scale measures daytime sleepiness. The patient rates likelihood of falling asleep in 8 situations from 0 to 3. A sum of 10 or more indicates significant daytime sleepiness. The Functional Outcome of Sleep questionnaire, or FOSQ-10, measures the sleep-related functional status. It provides a composite score of 5 subscales: activity, vigilance, productivity, social, and intimacy. The lower the score, the greater the impairment. Normal is around 17. The Sleep Medicine Center is responsible for sleep testing, sleep study interpretations, and treatment plans. In the Sleep Center, the testing process includes diagnostic monitoring and CPAP titration. As I told you earlier, patients are scheduled for a home sleep test or an in-lab polysomnogram according to OSAS risk as assessed by the stop bang tool. Patients at high OSAS risk are scheduled for a home sleep test. If the home test is positive, they return for a home auto CPAP titration to determine the best CPAP level. Patients with clinical suspicion for OSAS but without high OSAS risk according to the stop bang tool, and those for whom the home test is non-diagnostic, come to the sleep lab for polysomnographic testing. If the polysomnogram indicates OSAS, in-lab CPAP titration can be done the same night, or outpatient auto CPAP titration can be done later. Soon after testing, the tracings are scored, reviewed, and interpreted by a sleep medicine specialist. The test results are combined with clinical information from the clinical assessment tools and electronic health record to develop a treatment plan. Home testing is done over one night. Patients come to the sleep center the day of the study to set up the device and the next day to return it. It's a two-step process: the overnight diagnostic testing, and if OSAS is documented, outpatient CPAP titration with an auto-adjusting device over 7 days. Home testing is less expensive and provides greater access to sleep testing than in-laboratory testing. The disadvantages are that it's a newer technique just enjoying widespread use, and standard rules for scoring and interpretation have not yet been published. Also, home testing has a lower sensitivity and specificity for diagnosis of OSAS. Since patients who have had home testing are screened as high risk, negative or non-diagnostic tests should be followed up with in-laboratory testing for confirmation. Here's an example of a typical traditional home testing device and the tracing. The traditional devices sense airflow, effort via movement of the chest and abdomen, oxygen saturation, movement as a surrogate for wake periods via a risk actimeter, snoring, and body position. Besides the traditional devices, there are alternative home sleep study devices, such as the Aries, worn on the head at night, and the WatchPat that senses apneas or hypopneas by changes in peripheral arterial tone. In-laboratory polysomnography is the gold standard sleep test, but it's more costly and less accessible than home sleep testing. It requires an overnight stay in the sleep lab with constant technician attendance and a more lengthy process of scoring and interpretation. Polysomnography has two major functions: diagnostic monitoring and treatment assessment, like CPAP titration for OSAS patients or advanced BiPAP titration for patients with central sleep apnea syndromes or neuromuscular disorders. Here's a patient having polysomnographic testing in the laboratory and a tracing. Polysomnography requires multiple channels, including at least 4 EEG channels, eye movement channels, EMGs to measure muscle tone, respiratory channels, limb movement channels, and body position sensors. The polysomnographic tracings allow sleep staging, diagnosis of more complicated respiratory and non-respiratory disorders, and treatment assessments. Patients found to have OSAS must undergo CPAP titration either in the lab or at home. The goal is to find the lowest CPAP level needed to keep the apnea-hypopnea index less than 10. Home CPAP titration is done using an auto-adjusting device, or APAP. Data is downloaded from the device and an optimal pressure is determined. In some practices, patients are prescribed APAP indefinitely, thereby bypassing the titrating step. The Sleep Medicine Center initiates a plan for treatment and monitoring CPAP adherence and efficacy. Once a diagnosis and treatment plan for OSAS has been established, patients are educated about the condition and treatment. Patients who are prescribed CPAP are set up with the mask and device, either in their homes or at the center. They should be assessed for adherence and efficacy within the next month. Some patients require several encounters for further adjustment and troubleshooting until adequate adherence and efficacy are achieved. Why treat OSAS? For patients with moderate to severe OSAS, CPAP reduces associated cardiovascular events, including myocardial infarction and stroke, improves mortality risk, reverses the obesity hypoventilation syndrome, decreases risk of motor vehicle accidents, and improves well-being and quality of life, as well as neurocognitive and daytime functioning. At present, the medical sequelae for mild to moderate OSAS are unclear, and we don't know if it should be treated when asymptomatic. There is, however, good evidence that effective CPAP treatment does improve well-being, quality of life, and daytime functioning in patients with mild to moderate OSAS who have daytime symptoms. Numerous studies have shown that OSAS treatment decreases utilization of healthcare resources by reducing hospitalizations, outpatient visits, and pharmaceutical use. Medical costs are also reduced. A recent study done in 2012 showed that $81 per member per month, almost $1,000 per year, was saved just by prescribing CPAP for patients diagnosed with OSAS. OSAS treatment is aimed at three mechanisms: increasing pressure within the airway to stent it open, decreasing the surrounding soft tissue pressure, and increasing upper airway tone. CPAP, which increases airway pressure, is the most widely used and efficacious treatment. This is a typical CPAP device, which consists of the pressure generator and a humidifier that can be set at different levels. There's been a rush of CPAP technology that now provides individualized treatment and greater comfort for both the patient and bed partner. Different patients prefer different masks, and you can see some of the many types of masks that are available, including nasal masks for children and adults, nasal pillows, and full-face masks. Some patients benefit by using a chin strap that keeps the mouth closed to reduce mucous membrane drying and air leak. This is a hose blanket that reduces water condensation in the tubing from the humidification system. Here are the Centers for Medicare and Medicaid Services criteria for CPAP treatment. Moderate and severe OSAS, which is defined as 15 or more events per hour. Or mild OSAS with daytime symptoms or impairment or cardiovascular disease. In some states, Medicaid requires in-laboratory polysomnography to document OSAS before it will cover CPAP costs. How much CPAP is enough? The lowest effective pressure should be used. Almost all adult patients respond to a pressure of 6 to 18 centimeters of water. The conventional but rather arbitrary definition of CPAP adherence is usage 70% of sleep time, or at least 4 hours per night, 5 nights per week. But optimal effectiveness is achieved when patients use CPAP whenever they are sleeping. One study found a dose-response relationship between hours of nightly use and effectiveness that plateaued at 7 hours per night use. A major concern has been the lack of CPAP adherence limits its usefulness. In fact, CPAP adherence is similar to adherence for other treatments like metered dose inhalers, oxygen, and seizure drugs that cannot be measured as easily. The first night's use predicts long-term adherence, so early follow-up and support are important to provide the opportunity for troubleshooting and tolerance promotion, such as mass desensitization and stepwise pressure increases. And contrary to myth, studies have shown that adherence is not necessarily better with BiPAP than CPAP. All of the modern PAP systems have tracking systems that allow data from the devices to be downloaded to track adherence and effectiveness. Most tracking systems use a secure digital card, a memory stick, or a wireless connection. These systems have become invaluable for troubleshooting and optimizing adherence. Once started, most third-party payers, including Medicare and Medicaid, continue to cover CPAP treatment, including mask and hose changes, every 6 months to 1 year. Medicare allows 90 days for patients to get used to CPAP. To continue CPAP coverage, a face-to-face provider visit is required after the first month and before the end of the 3rd month. That visit must provide documentation of efficacy and adherence with an electronic data report that confirms 4 or more hours of nightly use, 5 nights a week, or the equivalent for 30 days. There are several simple interventions for OSAS that can be helpful when used with CPAP or as alternative remedies for patients that can't tolerate CPAP or have mild asymptomatic OSAS that may not require CPAP treatment. Opening and reducing upstream negative pressure in the nasal passages using nasal sprays can be an important intervention for patients with chronic rhinitis. We often prescribe ipratropium and corticosteroid nasal sprays to be used at bedtime. Weight loss may allow reduction in the level of CPAP needed, but may not entirely eliminate the need for CPAP therapy. Positional therapy, avoiding sleeping supine, has been shown to work as well as CPAP for patients with mild to moderate positional OSAS. Positional t-shirts and belts that encourage sleeping in the lateral position are available and can be bought on the internet. And finally, alcohol and sedatives reduce upper airway tone and should be avoided at bedtime. Other more invasive and more expensive interventions for OSAS include surgery, dental devices, and hypoglossal nerve stimulation. There are a variety of surgical procedures for OSAS. Uvulopalatal-pharyngoplasty, or UPPP, has been available for a number of years. It's effective for snoring, but less so for OSAS. Other surgical approaches may combine procedures like UPPP with operations that bring the jaw forward and open the airway. The most common dental devices are mandibular advancing devices, or MADs. There are several types. In general, they are effective for patients with mild to moderate OSAS. Studies have suggested they are better tolerated than CPAP, but they can be substantially more expensive. Hypoglossal nerve stimulation is a new procedure. It's a pacemaker that can be turned on at night to stimulate the genioglossus muscle and bring the tongue forward to open the airway during inspiration. OSAS is a chronic disease. Most of our OSAS patients will need lifelong treatment. To derive value from the diagnostic and treatment initiation process we've just gone through, we must continue to monitor our patients' adherence and provide long-term support. Our OSAS patients will be served best and most efficiently when long-term management continues in our clinics as a partnership between PCP and Sleep Medicine Center. We can maximize the health and well-being of our OSAS patients while saving medical costs through communication and coordination. The emerging model of OSAS care provides a collaborative effort between PCP and Sleep Medicine Center with the goal of achieving the best possible long-term outcomes for OSAS patients. PCPs may need to provide the specific OSAS care if there is no local sleep medicine program. Your OSAS patients receive education at the Sleep Medicine Center or by the DME provider when CPAP treatment is initiated. They may be given contact information to receive help as needed. At some centers, patients are given a calling card so that they can call and receive walk-in assistance and care as needed during office hours, Monday through Friday, 8:30 a.m. through 4:30 p.m. Your CPAP patients may be asked to return to the Sleep Medicine Center or check with the DME provider one or several times after CPAP initiation for data download and adjustment until settings and adherence are optimal. Your CPAP patients may need a visit with you or the sleep medicine clinic within 30 to 90 days after CPAP is initiated for documentation of adherence and benefit required to allow the patient to continue CPAP. Patients followed in sleep medicine clinic receive follow-up care as needed, usually within a routine visit 6 months after the first visit and then yearly. In between visits, patients are encouraged to contact the center for questions as well as equipment and other problems. We have covered the basics of OSAS, pathophysiology, complications and consequences, screening and testing, as well as treatment and long-term management. So here's a very basic take-home. OSAS is a highly prevalent, underdiagnosed medical disorder. It has a complex pathophysiologic basis with anatomic, physiologic, and central nervous components. Untreated, it leads to a variety of medical complications and high mortality rates. OSAS is a public health issue with high risk of motor vehicle and industrial accidents. It reduces quality of life and productivity. OSAS patients have higher healthcare utilization and medical costs. Treatment of OSAS can improve or reverse these complications and consequences, as well as reduce medical costs. OSAS patients are best served by good communication and collaboration between PCP and Sleep Medicine Center. The PCP identifies and participates in the initial assessment of patients at risk of OSAS and long-term follow-up. The center performs a detailed sleep medicine assessment, testing and treatment initiation, and with the PCP provides long-term follow-up. Thank you for your participation. To receive CME credit, please click on the link below.